You walk around every single day wearing well, a suit of armor.
Right, but not exactly made of steel.
No, exactly. It's not Kevlar,
Yeah.
and you don't wear it on the outside, obviously. It's made entirely of bone. It's completely internal. And its singular biological purpose is to protect the softest, most incredibly vulnerable part of who you are.
Your central nervous system.
Yeah. Welcome to another deep dive. Today, our mission is to decode the terminology, the pretty violent medical history, and the underlying mechanical engineering of this anatomical armor.
And we're really zeroing in on 3 core roots today. So Cranio, Spondylo, and Vertebro.
Right, and it might sound like a simple vocabulary lesson at first glance, but it's really not. We're talking about 7,000-year-old Stone Age brain surgery.
Which is wild to think about.
Totally wild. We're looking at survival against impossible odds, and the underlying genetics that dictate why a giraffe's neck is fundamentally built on the exact same blueprint as a tiny field mouse.
Because that biological safe room, that armor, has to be uncompromising. The nervous system is basically this highly delicate, really gelatinous mass that is notoriously terrible at repairing itself.
Yeah, neurons generally don't regenerate after severe trauma, so the armor has to be tough. Okay, let's unpack this. But before we get into how the armor works, we have to define what it actually is.
Which a lot of people get wrong.
Exactly. We get the terminology backwards every single day. People use cranium and skull interchangeably all the time. But equating the cranium with the skull is, it's basically like pointing to the roof of a house and calling it the entire house.
That's a perfect way to put it. The root Cranio strictly defines just the brain case. It's this highly specialized mosaic of exactly 8 bones.
Right, like the frontal, occipital, parietal bones.
Exactly, and the sphenoid, ethmoid, and temporal bones. Their only job is to form that sealed protective vault enclosing the brain itself.
Well, the skull, anatomically speaking, is the complete skeleton of the head.
All right. Right, so it's those 8 cranial bones plus the 14 facial bones, like the mandible and the maxillae.
So if a neurosurgeon is performing a craniotomy, they are penetrating the brain case. They aren't going anywhere near the facial structures.
No, not at all. A cranial fracture and a facial fracture are entirely different clinical situations with very different risks.
And then, as we move down from the head to the spine, the vocabulary gets even more complicated because we have 2 completely distinct root words for the exact same structure.
Vertebro and Spondylo?
Yeah, which honestly seems totally redundant at first glance. Why do we need 2 words for the spine?
Well, what's fascinating here is that this dual vocabulary is really a living linguistic fossil. It goes all the way back to the Renaissance university system.
Oh, wow. Right.
Yeah, because as medical education formalized across Europe, physicians needed a universal language. An anatomist in Paris had to be able to clearly communicate with a surgeon in Bologna. So they pulled from both Latin and Greek.
Right, with vertebro being the Latin root.
Exactly. It comes from vertere, meaning to turn, which perfectly describes how the spine actually pivots. Andreas Vesalius cemented this in 1543 with his famous anatomy texts based on direct human dissection.
Overturning all those old animal-based assumptions.
Right. He locked in vertebro to describe normal, healthy anatomy.
And then spondylo is the Greek counterpart, from spondylos, which means to pour or build up in layers, right? Like stacked bones.
Spot on. But it wasn't used for normal anatomy back then. It was revived in the 19th century by orthopedic surgeons specifically to categorize pathology and disease.
That actually makes perfect sense. So if you're talking about a healthy structure, you use the Latin vertebral column, but the second there's a disease, the vocabulary shifts to the Greek, like spondylosis.
Exactly. It creates this beautifully organized clinical system.
So going back up to the cranium, we had this rigid vault of 8 fused bones. But a completely sealed box would be useless.
Right. The brain has to connect to the body. It needs massive blood flow and has to transmit sensory and motor signals.
Which brings us to the foramen magnum, literally the great hole.
Yeah, positioned right at the base of the skull in the occipital bone. It's the definitive handoff point where the brainstem officially becomes the spinal cord.
It's the strategic gateway. But when that cranial armor is forcefully breached, not through the gateway, but through the bone itself, the body's response is just wild.
Absolutely.
I mean, look at Phineas Gage in 1848, the most heavily analyzed case of cranial trauma ever. This 25-year-old railroad worker is packing explosives with a 13-pound iron rod.
A 4-foot-long rod, too.
Yeah. The explosive goes off prematurely, and this massive rod shoots straight up to his left cheek, behind his eye, and blows right through the top of his cranium.
Taking a huge chunk of his frontal bone with it.
And it lands like 80 feet away. The physical trauma was catastrophic. It completely decimated his left frontal lobe.
But the crazy part is he was walking and talking within minutes.
Which makes no sense. And he lived for another 12 years. His personality fundamentally changed because of the frontal lobe damage, but he survived.
And surviving a high-velocity breach like that seems like a total anomaly. But if you look at the archaeological record, humans have actually survived cranial breaches for millennia.
Here's where it gets really interesting. Because you look at these Neolithic skulls from over 7,000 years ago, and they have these perfectly clean, deliberate circular holes cut right through the bone.
Trepanation.
Yes, trepanation. And the procedure itself is brutal. But the outcome data is staggering. The bone edges on these ancient skulls are smooth.
Which means the osteoblasts had time to remodel the bone.
Exactly. The patients healed. They survived for years after someone cut into their brain case with, like, stone tools. No anesthesia, no germ theory. The sheer resilience is unfathomable.
And there's a lot of active debate in the scholarly community about why they even did it.
Right, because we want to look at both sides impartially here.
Exactly. Some anthropologists interpret it as a practical medical intervention, like maybe relieving intracranial pressure from head trauma or subdural hematomas.
But others see it as purely ritualistic. Right. Trying to release spirits that were causing epilepsy or migraines.
Right. And realistically, it was probably a complex mix of both, depending on the specific ancient culture. But the survival rate is what's truly astonishing.
Especially when you consider that even by the 1930s, performing a standard craniotomy in a modern hospital had a mortality rate of around 50%.
Yeah. Half of the patients died. Surgeons just couldn't control the hemorrhaging from the brain tissue or stop post-operative infections.
Until Harvey Cushing came along, the father of modern neurosurgery. He teamed up with a physicist, William Boovey, and they developed the electrocautery device.
Which was a total game changer. Instead of trying to mechanically tie off microscopic bleeding vessels, they used a high-frequency current to just instantly heat and seal them.
Without burning the surrounding delicate tissue. By doing that, Cushing dropped the mortality rate from 50% to roughly 10%. He finally figured out how to safely navigate the armor.
He really did.
So that's the rigid helmet. But as we move through the foramen magnum into the spine, evolution faced this brutal mechanical conflict.
Right, because the central nervous system needs armor, but a solid, inflexible bone tube would turn you into a statue.
Yeah, you could run, twist, look around, you'd just be a stiff rod.
So the evolutionary solution was a segmented, mobile tunnel, 33 individual bony rings, the vertebrae stacked up and separated by these shock-absorbing intervertebral discs.
And the layout is so conserved. You've got the thick body in the front, the arch in the back, enclosing the canal. But the regional specialization is insane, especially in the neck.
Oh, the cervical vertebrae are incredible. The top two, C1 and C2, are so structurally distinct they actually have their own names, the atlas and the axis.
C1 is the atlas, right? Like the Greek titan holding up the world, except it's holding up the cranium.
Exactly. It's basically just a bony ring, no vertebral body at all. And C2, the axis, has this upward-pointing peg called the dens.
And the atlas literally just rotates around that peg.
Yeah. Yes, and that single joint right there facilitates about 50% of the rotational mobility in your entire neck.
That's how we turn our head side to side.
Yep. It's this delicate, brilliant piece of engineering, and it's governed by a really rigid set of genetic instructions. Which brings us to the mammalian rule of 7.
Oh, I love this part. Basically, all mammals, whether you're talking about a tiny mouse, a human, or a whale, possess exactly 7 cervical vertebrae.
Even the giraffe.
Right. And when I first heard that about the giraffe, it blew my mind. Because it's like having a small Lego kit for a toy car and using that exact same kit to build a skyscraper.
Right, you can't add any extra pieces.
Exactly. You just have to stretch the blocks you already have. The giraffe's neck bones are just massively elongated, scaled-up versions of our own 7 neck bones.
And if we connect this to the bigger picture, it underscores why we rely on those regional prefixes in medicine. Cervico for the neck, thoraco for the chest, lumbo for the lower back.
Because they aren't just the same bone copied 33 times.
Not at all. A cervical vertebra has specialized tunnels for arteries going to the brain. That is structurally fundamentally different from a massive lumbar vertebra that has to carry the weight of your entire upper body.
But because it's such a complex mobile tunnel, it breaks down. And honestly, people totally misunderstand how it works. Like when people crack their backs.
Yeah. The misconception there is huge.
People think a bone is like physically popping back into place.
Right, but the physics dictate something entirely different. It's just cavitation. When you stretch the joint, you pull the capsule apart and drop the pressure inside the synovial fluid.
And the dissolved gases, like carbon dioxide, just vaporize into a bubble.
Exactly. And when the pressure equalizes a split second later, the bubble collapses with a loud pop. The bones themselves aren't grinding or relocating at all.
Understanding that actually makes the real pathology easier to grasp. Let's go back to those Greek terms, spondylosis versus spondylitis.
Two very different things clinically. Spondylosis, with the OSIS, is a degenerative process. It's basically mechanical, age-related wear and tear, osteoarthritis of the spine.
Right, the discs dehydrate and thin out, and you get bone spurs.
But spondylitis, ending in itis, is inflammatory. It's an active disease process, often autoimmune, like ankylosing spondylitis.
Which is tied to that HLA-B27 genetic marker.
Yes. The immune system mistakenly attacks the entheses, the spots where tendons and ligaments attach directly to the bone.
And to heal that constant inflammation, the body lays down new bone. And over time, it actually bridges the gaps and physically fuses the vertebrae together.
It literally turns the spine back into a rigid, dysfunctional rod. On an X-ray, it looks like a solid bamboo stalk.
Which is why diagnosing the difference is so crucial. Spondylosis just needs physical therapy and anti-inflammatories. Spondylitis needs heavy biologic therapies to stop the immune system before the fusion is permanent.
Exactly. And another major mechanical failure is spondylolisthesis. Listhesis just translates to slipping.
Yeah, this is when a vertebra slips forward over the bone beneath it, usually right at the L5-S1 junction where the lower back meets the sacrum.
It's very common in young athletes. Gymnasts, American football linemen, anyone constantly hyperextending their spine under a heavy load.
Because it puts massive shear force on this tiny piece of bone called the pars interarticularis. Once that fractures from stress, there's nothing holding the vertebra back. It just slides forward and crushes the nerve roots.
It's a brutal mechanical failure. But, speaking of failures, there's a much darker history of how humans have misunderstood and misused this anatomy entirely.
Oh, you mean craniometry in the 19th century? Yeah, that is a stark example.
Absolutely. You had figures like Samuel Morton collecting skulls from all over the world, meticulously measuring their internal volume.
And he claimed he was just cataloging objective anatomical data, right? Asserting that cranial capacity directly dictated intelligence.
But then he completely weaponized that data to construct these pseudoscientific racial hierarchies.
It was literally the definition of scientific racism, using fake empirical measurements to justify systemic bigotry.
And it took decades for evolutionary biologist Stephen Jay Gould to publish The Mismeasure of Man. He rigorously reanalyzed Morton's data and impartially exposed the severe methodological flaws.
Yeah, Morton was consciously and unconsciously skewing his measurements, excluding certain samples to make sure the numbers matched his preconceived biases. We just have to impartially recognize how anatomy was weaponized there.
Exactly. But even setting aside historical pseudoscience, modern clinical neurology still grapples with incredibly complex debates regarding the cranium.
Like the surgical debate between a standard craniotomy and a decompressive craniectomy for traumatic brain injury.
Right. Because when severe trauma happens, the brain swells, but it's trapped in a rigid box.
So the pressure skyrockets, and the brain effectively crushes itself against the bone, cutting off its own blood supply. It's terrifying.
To relieve that pressure, neurosurgeons can do a decompressive craniectomy. They remove a massive section of the skull, but unlike a craniotomy, they don't put the bone flap back right away.
They literally leave the skull open. So the swelling brain tissue can herniate outward safely past the armor. And they keep the bone in a freezer, or sometimes inside the patient's abdomen, to put back months later.
But the debate here is really about the long-term outcomes. And we want to look at this impartially based on the major clinical trials from the 2010s, like the DCRA and RescueUp trials.
Right. And the data from those trials showed a brutal paradox. Decompressive craniectomy undeniably reduces mortality. It keeps people alive who would 100% die from the pressure.
However, the quality of that survival is highly debated. A substantial percentage of patients saved are left in a vegetative state or with really profound permanent neurological disability.
So it's this live, ongoing debate about the threshold of intervention, balancing the preservation of biological life against preserving meaningful neurological function.
It's incredibly difficult.
So what does this all mean? Taking all this history, the Greek and Latin roots, the rigid cranium, the mobile spine, how does it dictate everyday public health and emergency medicine?
Well, it dictates the absolute non-negotiable protocols for first responders. If you look at a severe car crash, the very first thing a paramedic does is apply a rigid C-collar to the neck.
Because the physics of what's happening inside are so dangerous. If you have a fractured cervical vertebra, that protective tunnel is compromised.
Right. Any movement could cause those bone fragments to shift and physically sever the spinal cord.
Immobilizing the neck in those crucial first 10 minutes is the only thing preventing a fracture from turning into permanent quadriplegia.
And we see those exact same mechanical vulnerabilities in diving accidents. Diving headfirst into shallow water is catastrophically dangerous because of C1, the atlas.
Because, like we said earlier, C1 doesn't have a vertebral body, and it doesn't have a fibrocartilaginous disc to cushion it against the skull.
Exactly. So when a diver's head hits the bottom of a pool, the sudden deceleration force totally bypasses the cranium. With no shock absorber, all that kinetic energy goes straight into the fragile C1 ring.
And the force just shatters the atlas, driving bone fragments laterally into the brainstem. The mechanism of injury is purely structural.
It really gives those pool safety warnings some serious weight.
It really does. But, on a slightly less terrifying note, this engineering also dictates human birth. A lot of people assume babies are just born with tiny, solid adult skulls.
Which would be a biomechanical impossibility. If a baby had a fused, rigid cranium, it could never navigate the birth canal.
Instead, it's this assembly of independent, unfused plates, joined by flexible fibrous joints called sutures and those big sock spots called fontanelles.
This temporary flexibility allows the plates to actually overlap and mold under the compressive forces of delivery.
And more importantly, it allows the brain to grow after they're born. The human brain nearly triples in volume in the first year.
If the skull was fused at birth, the expanding brain would lethally compress itself against the bone.
Those sutures don't fully fuse until a child is about 18 months old. And if they fuse prematurely, which is called craniosynostosis, surgeons actually have to go in and reopen them.
Just to artificially recreate that space so the brain isn't permanently damaged by the pressure, it all comes back to managing that rigid box.
It really does. Let's quickly recap what we've covered today. We distinguished the cranium, just the 8 brain case bones, from the entire skull.
We looked at the linguistic divide from the Renaissance, using the Latin vertebro for normal anatomy and the Greek Spondylo for pathology.
Right, contrasting the mechanical wear of spondylosis against the calcifying autoimmune fusion of spondylitis.
We explored the incredible engineering of the atlas and axis for neck rotation and the foramen magnum bridging the cranium and the spine.
Plus all the mechanical failures, from spondylolisthesis in athletes to the severe pressure dynamics requiring decompressive surgery.
Which brings us to an important question, and this is something I'd love for you to think about as you go about your day. We talked about those deeply conserved Hox genes and the mammalian rule of 7.
Right, how mammalian evolution locked our blueprint and the giraffes into exactly 7 neck bones for millions of years.
The anatomical code is practically unchangeable. And yet today, we are abruptly subjecting this ancient structure to entirely novel mechanical loads.
Oh, you mean like tech neck?
Exactly. We spend hours every single day locked in cervical flexion, just staring down at our screens.
Yeah.
If our bony blueprint is genetically locked at 7 vertebrae, and evolution won't just rapidly give us a new anatomical structure, how will our soft tissues and discs ultimately adapt to a mechanical demand they were never engineered to support?
That is a tremendous concept to walk away with. We are navigating this hypermodern environment while bound inside a deeply ancient, totally unyielding suit of bone armor. And every single piece of that armor has its structural threshold. Thank you so much for joining us on this deep dive. Keep questioning the physical structures around you and inside of you. We'll catch you next time.